Welcome. I'm Whitney Ross, the Executive Director of Trinity Counseling Service, and you're joining us for the 8th speaker series at Trinity Counseling Service. We're virtual tonight, but we started a speaker series as part of the COPE program at Trinity Counseling Service. COPE is the Community Outreach, Prevention, and Education program. And we started it when I started in my role at TCS almost 8 years ago, in an effort to get as much mental health education and information to the community as possible. Because while one-on-one therapy and counseling is great and so important, it's limiting and it's limited. And so providing talks and workshops and education in this format and via our social network and on our website is an opportunity to bring experts in fields, bringing their research and their areas of expertise to the community is a wonderful way to disseminate more information. So we have 3 topics over the next 3 months, and this is our first evening. We're so happy to have people joining us. We hope that people will join us for the next 2 talks over the next 2 months. And speaking of a wide audience, we do have a really great and wide audience tonight. We have TCS, Trinity Counseling Service clinicians joining us. We have clinicians in the wider community and really across the country, actually, by virtue of being able to be in remote status. We have members of the community. We have doctoral students in clinical psychology and undergraduates joining us, and people just interested in the field of mental health, and specifically in EMDR, eye movement desensitization and reprocessing. So we are thrilled to have Michael Baldwin and Dr. Deborah Korn with us this evening. Michael Baldwin is a leader in advertising and communication in the advertising and communication industry for more than 35 years. In addition to writing this terrific book, he has written Just Add Water, an easy guide for creating simple, powerful presentations, which, by the way, I ordered today, and I'm looking forward to getting. And Dr. Deborah Korn, a psychotherapist, consultant, and researcher. She sits on the faculty of the EMDR Institute, and on which she served for more than 25 years. And let me know if I get any of this wrong, by the way, guys. And she sits on the editorial board of the Journal of EMDR Practice and Research, and is a regular presenter at the EMDR International Association Conference. Tonight, Michael joins us from New York and Debbie from her home in Cambridge, and we're so happy to have you with us. Honestly, I've read your book, as have many members of our staff, loved it, and look forward to a wonderful presentation. Debbie and Michael will present for about 40 minutes, and then we have at the bottom of the screen in the chat feature, feel free to, as we're listening, throw questions into the chat function. Debbie, Michael, and I are the only ones who will see the questions, but I will take careful and copious notes. And at the end, the last 15 minutes or so, I'll come back and facilitate a Q&A. If we have time to get to the questions, all of the questions we will. If not, we will do our best to throw them up, Q&A answers, questions and answers in our social media, on our social media and on our website, if that's okay with you all.
Yeah.
So thank you all, and thank you both, and I'll see you in 40 minutes or so.
Great, thank you. Michael, you want to start us off?
Sure. First of all, thank you for having us. It's a pleasure to be with all of you tonight. We're going to start with Debbie, and just maybe you could give this group or start by answering the question, what is EMDR therapy? And in particular, what do the letters of its acronym stand for?
Mm-hmm. Yes, absolutely. So EMDR stands for eye movement desensitization and reprocessing. It's a mouthful, it's an earful. Desensitization refers to the focus on reducing fear and anxiety and distress. Reprocessing refers to the reevaluation or the restructuring of thoughts and beliefs and the transformation of one's sense of self relative to past traumatic experiences. So reprocessing leads to resolution. It allows people to move the past into the past so they can live and carry on more fully in the present. And EMDR was developed by psychologist Francine Shapiro in the late 80s. She would ask clients to focus on a relevant traumatic memory and then instruct them to follow her fingers with their eyes as she moved them horizontally back and forth in front of their face. Hence the name eye movement, desensitization and reprocessing. And I'll talk a bit more about the function of the eye movement component later in our presentation. As wacky as the eye movements may sound, I promise you that there is solid research and clinical findings in support of this component of EMDR therapy. And over the years, we've learned that in addition to eye movements, many other forms of back and forth stimulation, what we call bilateral stimulation, are effective as well. So having a client listen to alternating tones like beep, 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 or tapping back and forth on a client's hands as they rest them in their lap, or what we call the butterfly hug, crossing their arms, the client crossing their arms over their chest and tapping on their own shoulders or tapping on their own kind of chest area. So EMDR is, it's a memory-focused psychotherapy that helps people deal with the impact and legacy of trauma and adverse experiences in their lives. And it's based on the idea that psychological problems are related to the failure to adequately process traumatic experiences and memories. So unprocessed traumatic memories frozen in our nervous system continue to affect how we perceive things, decisions we make, reactions we have, the beliefs we hold about ourselves and others. Unprocessed traumatic memories directly lead to symptoms that cause ongoing distress. And EMDR is best known as an evidence-based treatment for post-traumatic stress disorder, but it is in fact being used to effectively treat a very wide range of disorders, symptoms, and issues. It's being used in groups, it's being used as an adjunct to traditional talk therapy, and it's being used in intensive kind of consecutive day formats now. And it's a therapy that can be helpful even when someone doesn't self-identify as a trauma survivor.
Okay, so maybe you could also say something about how we define trauma in our book.
Yes, for sure. So we see trauma as part of life. And in our book, we define trauma quite broadly. We define it as any experience that feels overwhelming, triggers strong negative emotions like shame or terror, and involves a sense of powerlessness or intense vulnerability. When we talk about trauma, we may be talking about situations where something happened to you, right? Emotional, physical, or sexual abuse, traumatic losses, witnessing or experiencing violence, natural disasters, combat, medical trauma, and or situations where things were supposed to happen but didn't. So situations where you were not properly protected, where you were not properly listened to, cared for, or valued. So here we're talking about experiences of neglect, deprivation, abandonment, alienation. And we talk about big T, shock traumas, and the cumulative effects of small t traumas. So small t traumas, criticism or betrayal, experiences involving humiliation or failure or aloneness, subtle microaggressions, as well as blatant discrimination or hostility. So examples in adulthood of small t traumas might be a divorce, losing a job, a difficult move, the discovery of a partner's affair. Examples in childhood of small t might be, or what we might call developmental trauma, feeling ignored, feeling different, feeling unable to measure up, or powerless to control the craziness or the chaos in your family. And the greater the number of adverse experiences that someone is exposed to, the greater the potential for psychological or physical toll. And it's important to note that trauma is both objective and subjective. So it's both what happened and how you experienced what happened. So no two people are going to respond the same to a particular kind of event.
So would you say then that there's a difference between the way our brains process a traumatic memory versus how our brains might process or make sense of ordinary everyday experiences or challenges?
Yes. We regularly process experiences every day without difficulty, right? Under normal circumstances, like let's say we go to a party, we see our friends, we eat good food, we make conversation, we go home that night and we process the experience. We reflect on it. Maybe we talk to our partner about the experience. Maybe we go to sleep that night and we have a dream about the experience. But by the next day, we have processed through that experience. It goes up on a shelf, it moves into the past, and we move on. When we're talking about traumatic circumstances, something very different appears to happen. With trauma, the experience gets frozen or locked in the nervous system, and it gets frozen along with all the components of the experience, the images, the feelings, the sensations, the thoughts, the impulses that were part of the original experience. The brain's information processing system is unable to digest or metabolize the experience, and other information held elsewhere in memory doesn't get connected in, it doesn't get integrated to help make sense of the event. So when you're triggered, when traumatic memories get activated, the past becomes the present. People lose their adult, present day grounding and perspective, and all of a sudden they're feeling panicky, or they're feeling frozen, or they're feeling overwhelmed with shame, ready to fight, feeling like they're 12 years old again. Old thoughts and feelings take over. A person might feel hijacked by those old feelings and thoughts. Thoughts like, I'm unlovable, or I'm bad or worthless, I'm unsafe or in danger, I'm helpless, I'm powerless, I'm trapped. And then as people find themselves in distress, in pain, they turn to things like drinking or drugs or self-injury or other behaviors to soothe themselves, to avoid, or to numb out. So you can understand why we might be interested in getting to those unprocessed trauma memories at the core.
So telling us a little bit more about what EMDR therapy involves, or what someone might expect if they're contemplating or beginning EMDR therapy.
Yeah. Well, early sessions involve taking a thorough history. The therapist takes a thorough history. There's a focus on establishing safety and trust within the therapeutic relationship. And there's sometimes a focus on resourcing or skill building work if needed to make sure that a client is ready to approach challenging emotional material. We don't want to move forward if there's any chance that there's going to be a negative response or negative consequences of moving into the trauma material. Now, most people don't show up saying, I want to work on my traumatic memories from age 5 or age 12, right? Most people walk through our doors and say, I'm miserable, I'm having trouble coping, I'm having marital problems, I'm depressed, I'm anxious. Maybe if someone's more educated, they might say, I think I have PTSD symptoms. So we begin with the current distress that people present, and we float back from there. We ask folks to think about a recent experience of a symptom or recent experience of distress, to notice the feelings, the sensations, the words that come up with it, and then to float back, tracking in their body back over time, looking for the root of the distress. When's the earliest time or the first time you remember experiencing something like that? And we search for relevant memories to target. And once a target memory is identified, we activate the memory with a series of questions. Again, what picture represents the worst part? What are the words that go best with this image? What are the feelings? What are the sensations that come up with it? We activate the memory, and then we introduce sets of back and forth eye movements or sets of some form of bilateral stimulation. And the sets usually last 30 to 60 seconds, maybe, sometimes longer. And then we check in. I'll ask, I'll say, take a break. What do you get now? And with every set of bilateral stimulation, clients are asked to notice what changes for them. And they're asked to report on thoughts, feelings, sensations, insights, impulses. And the therapist invites the client to just notice again and again, to be a passenger on a train, watching the scenery go by, just noticing, always staying connected to the present moment, staying connected to the therapist, just witnessing from a distance. And I regularly am saying things like, it's old stuff, it's just a memory, just let it go by. Now, no two people process in the same way. There's no supposed tos or shoulds. Whatever comes up with each set comes up. And clients remember and they process. They process fear, grief, anger, guilt, and shame. We work to keep the processing somatically, body focused. So whatever clients are reporting, I will check in again and again. Where do you feel that? Just notice, it's just a memory. Stay with that, stay with what's coming up in your body. And in the course of processing, a client might imagine saying or doing whatever they never got to previously say or do, right? Raging at the person who hurt them, running away, fighting back with superhuman strength. It's not unusual for narrative to come up like that, or imagery to come up related to any of those kinds of things. They may spontaneously see their younger self and offer compassion or care to that part of themselves. But eventually the distress decreases and relevant adaptive information located in other parts of the brain gets integrated. And the goal is to be able to think about the memory by the end of the work without distress, to arrive at more positive beliefs about the self, about the world, and to get to a point where any remaining appropriate feelings, like if someone is feeling grief because they've just lost someone dear to them, we wouldn't expect the grief to be gone, but we would expect that those appropriate feelings become much more tolerable and manageable. And then maybe the last thing I'll say is that EMDR is a comprehensive psychotherapy. It's not just a technique, it's really a full-bodied psychotherapy. And we're very comprehensive in the way we work at things. We address past experiences that seem to be at the root of current disturbance. We target present trigger situations that are activating distress. And we ultimately help people move into the future. We ask them to imagine with their new sense of self, new feelings, new beliefs, imagine coping with challenging situations in the future. And we integrate that. We continue with the sets of bilateral stimulation, helping them to kind of take in that new sense of self.
So can you go back just a bit and maybe say something more about the actual role of eye movements?
Yes. There's a lot of research substantiating the positive effects of eye movements. We know now that eye movements reduce negative emotions and imagery vividness. We also know that eye movements increase or facilitate the remembering of events, the recognition of true information, what we might call insight, right? The ability to discern distortions from what's more accurate. Eye movements increase the flexibility of thinking or increase flexible thinking. And also eye movements facilitate positive neurophysiological changes. Now, there's many hypotheses about what might be happening in the brain that leads to desensitization and reprocessing. A few of those hypotheses have received considerable attention. The first is that eye movements tax working memory. Now, working memory is the type of memory we use when we're holding a recipe in mind while cooking, or when we're holding directions in mind while we're driving somewhere. And focusing on a traumatic memory while engaging with another activity like following bilateral stimulation leads to a reduction in the vividness and emotionality of traumatic memories by taxing that working memory. Working memory has a limited capacity before things start to break down, so to speak. Another hypothesis, eye movements also seem to activate the parasympathetic nervous system, leading to a de-arousal effect, a relaxation response. So de-arousal allows for more effective information processing. It keeps people in their window of tolerance. It allows them to tolerate staying connected to the traumatic material and eventually processing it to resolution. And finally, eye movements seem to activate the same neurological processes that occur in REM sleep, leading to reductions in negative emotion, more flexibility in thinking, increased associations between our memories, and increased insight, the same outcomes that we associate with REM sleep. So let's shift gears. And Michael, I want to ask you a couple of questions here. Could you talk about the inspiration for our book, Every Memory Deserves Respect? And maybe you could share something about how we came to write this book together.
Sure, of course. Well, here it is. And one of the I think just sort of unique aspects of the book are these things that we refer to as billboards that are a single image with very simple, very minimal text opposite the billboard to illustrate a key point or concept. So that's kind of where the book started. When I started my work with Dr. Jeffrey Magdamida, who was my therapist. So Debbie, just to be very clear, Debbie was my co-author. She was not my therapist. And as I started about 6 months into my work with Dr. Magdamida, I started to understand about trauma and about EMDR. So as a visual thinker, I started to come up with these things where I thought I might be able to communicate the things as I understood them to people who might also not be aware of them, like I wasn't, with one image and very simple text opposite, which came to be known as a billboard. I showed about 6 of these to Dr. Magdamida at one point, and he said, these are quite interesting. And he said, if you pursued that, this might actually be a book. And the only thing I had to do at that point was to go out into the world and find a leader in the EMDR therapy space who would be willing to write a book with someone they never met before in their lives, which is exactly what happened with Debbie over time. It didn't happen overnight, but it was eventually how we came to be co-authors for this book. But at the core, I was thinking about creating a book and had the hope that this book would help people. In other words, after hearing my story and the experiences of other clients that Debbie talks about in the book, people would feel more comfortable talking about their own stories, their own traumatic histories, trauma histories. I also, in particular, hope that men would understand that trauma may be at the root of many of their symptoms, like they were mine, and behavior patterns. And I say that because my sense is that men often need permission or encouragement to share their vulnerability and to seek help. Right. Debbie, you want to go add to that?
Yeah, sure. So Michael's story and the idea for a book were so compelling that I couldn't resist. I immediately got excited about creating an EMDR book unlike anything that had ever come before. One that my clients would actually read, one that I could share with my parents who've never really understood what I do for a living, one that I could share with my primary care doctor, my chiropractor, who've been asking me questions about trauma and EMDR for years. I just imagined a truly accessible and user-friendly book about trauma and about EMDR. One that answers the kinds of questions that people new to therapy tend to ask, and a book for those who self-identify as trauma survivors, and also for those who can't quite figure out why they're depressed or anxious or unable to maintain relationships. And, a book for EMDR therapists as well as non-EMDR trained therapists. And for other caregivers as well. In my dreams, this is a book that physicians or lawyers or probation officers or educators would also share with people.
So can you maybe outline or give the audience an idea of how the book is structured and maybe say a little bit about the material that we cover in each of the chapters?
Sure. So the book is written in 2 voices, the voice of a trauma expert, an EMDR expert, and the voice of a trauma survivor, an EMDR client. Michael shares his trauma history, his symptoms and struggles, his experience with EMDR therapy. He describes the process of transformation that allowed him basically to reclaim his life. I provide an overview of trauma. I talk about post-traumatic symptoms, the process of recovery, and the nuts and bolts of EMDR therapy. I also try to convey the wonder of this therapy approach and the profound nature of the transformation that we get to witness with EMDR therapy. Every chapter begins with some description, some narrative from Michael about his journey, about his life, and I follow with the didactic part. And I share case vignettes from my own practice throughout the book. And then finally, there are about 60 billboards, those 2-page spreads that Michael described earlier and showed you. And we're going to share some of those billboards with you as I now talk about some of the chapters of the book. You ready with that, Michael?
I am.
Okay. So the first chapter in the book is called "What is this thing we call trauma?" And in this chapter, I define trauma quite broadly and introduce readers to EMDR as an evidence-based treatment for trauma. I introduce the concept of unprocessed memories locked in the nervous system. Michael, you want to? Right. So here it says, traumatic experiences remain preserved in the brain and body, often unaltered from the moment they occurred. And here we have someone holding a piece of amber with a little flower frozen, locked in the amber. And of course, this represents this concept of these memories that get frozen and locked in the nervous system with feelings, sensations, cognitions, images, and other sensory experiences. And also in that first chapter, we discuss all of the different kinds of traumas: big T, little t, deprivation and neglect, institutional trauma, systemic racism. And then in chapter 2, which is called "How Does Trauma Affect Your Mind, Body, and Behavior?", I introduce PTSD, complex PTSD, and dissociative disorder symptoms. I talk about trauma-based disorders as disorders of dysregulation, right? Emotional, behavioral, relational, somatic, attentional, or dissociative dysregulation. Michael? So here we have a billboard of a thermostat that says emotional self-regulation is the ability to modulate your own emotional thermostat. So as we talk about all of these different ways, all of these different kinds of dysregulation that trauma survivors struggle with, we also begin to introduce the importance of learning to regulate your own nervous system. And so this concept is captured with this billboard. Also in this chapter, I talk about negative self-concept, the sense of alienation and aloneness that accompanies the experience of trauma, the loss of purpose, the struggles with self-care, the tendency to have poor boundaries or difficulties with limit setting. And I talk about the role of self-protective defenses. There's in particular, there's a big section on dissociation in this chapter. Michael, you want to put up the, yeah. So this billboard reads, children learn to hide the parts of themselves that are not tolerated by their caregivers. So in Michael's case, you'll hear this from Michael in a little while, but he worked very hard from a very early age to hide the parts of himself that carried the sense of worthlessness, the sense of being broken. And in our work, we really work to help people reclaim all parts of themselves, to to begin to relinquish those defenses and allowing them to connect with feelings and memories and parts of themselves. The next chapter is called How Does Trauma Affect the Brain? So here we talk about PTSD as a brain injury, not a reflection of weakness or flawed character. We take a very compassionate stance throughout the book, and we work hard to really reduce stigma. So this billboard reads, we can no more act normally with an injured brain than we can walk normally on a broken leg. So here the message is truly have compassion for yourself, right? You've endured a tremendous amount. Your brain really took a hit, and you are going to be able to heal. Your brain is going to be able to heal. We know that brains are able to heal, but you need to be patient and you need to have compassion. So in this chapter about the brain, we talk about what happens in the brain during a traumatic event, and we talk about memory processing, how it normally works, and what happens instead when someone is traumatized. And finally, in that chapter, we talk about the strength of EMDR as an experiential, body-based approach that integrates bottom-up and top-down processing. In chapter 4, what is EMDR therapy and how does it work? We take a deep dive into explaining EMDR here. We talk about the phases of EMDR, the issues of readiness for trauma processing, the idea that every client needs to work at their own pace. And we emphasize the importance of that dual attention, kind of staying grounded in the present, connected to the therapist as you dip into the past, as you access traumatic material. Michael? So this is one of my favorite billboards. Clients are passengers on a train watching the scenery go by. The therapist is the conductor. So again, just capturing that idea that, that EMDR is not about reliving. It's about bearing witness, observing, processing, and just staying grounded in the present as you just let that scenery go by, just noticing with each set what emerges. And as we talk about EMDR, we talk about the role of the therapist as a co-pilot, as a co-regulator, and as a coach. And I also talk about highlights from the world of EMDR research, which is very, very extensive at this point in time. Chapter 5 is called Contemplating Treatment. Am I ready? Can I really do this? I address fears and blocking beliefs that people come into therapy with. You know, will I have to relive everything? What if I don't remember? What if I don't want to remember or don't want to connect with painful feelings? Do I have to talk about everything? What if I can't tolerate the treatment? What if I dissociate? Michael. Right. So as you approach memories, your therapist will set a safe pace so you don't get in over your head. So this is a lovely billboard, which really just gives me an opportunity in the book to talk about accompaniment, to talk about working as a team in EMDR therapy. And that, you know, with my own clients, I always say, I'm going to be right here with you. I'm going to be here at your side. I'm not going to let you drown. Right. You know, this is not going to be like it was the first time around when you were so alone and so overwhelmed. You know, I will be right with you. Chapter 6 is called Keeping Your Eye on the Prize, the Promise of Transformation. And in this chapter, I talk about the kinds of changes I see in my clients, right? Symptom reduction, shifts in sense of self, shifts in relationships, shifts in the sense of safety and security and choice. Michael talks at length about his transformative experience. And I include also an excerpt from an interview I did with Michael's therapist, Dr. Jeffrey Magnavita, where he talks about what it was like to witness the changes in Michael. So here's a billboard from this chapter. An important aspect of recovery is the healing and reintegration of our child selves. So here with this billboard, I'm able to talk about how the aim of EMDR is integration, is wholeness, is about kind of greeting parts of self with compassion and really embracing all parts of self and kind of welcoming all parts of self back into that sense of identity and acceptance. And then the final chapter is called When You're Ready, Resources to Get You Started on Your EMDR Journey. So how do you find an EMDR therapist? Key questions to ask a potential therapist, questions to ask yourself. Michael? So this is a really fun billboard. I threw this in so you know we have a sense of humor. Finding the right therapist is a process. And we really try to give a message in the book that it is so very important to listen to what you need, to really take your time, to tune in, ask questions so that you find the right fit. You don't want to just be opening up a phone book and pointing to a therapist and starting there. And then I talk some in that last chapter about adjunctive EMDR therapy that can accompany other forms of therapy. I talk about intensive consecutive day EMDR therapy, which is becoming more and more popular. And I talk about other complementary healing modalities like yoga, neurofeedback, meditation, et cetera, that can, be used in conjunction with EMDR. And then we end the book with a very robust list of books and websites. So let me shift now to Michael and have Michael share a little bit with us about his story. Michael, in our book, you courageously share your personal story with readers. Would you be willing to share a little bit with our audience right now about your early years and about your trauma history?
Of course. And it started when I entered treatment with Dr. Magnavita. Because I knew I had a lot of bad things that had happened to me when I was young, but I never really conceptualized them as traumatic. And I had certainly never thought of them as having anything to do with my adult emotional struggles I was having present day. I never thought of myself as a trauma victim or a survivor. And also, I didn't consciously remember some of the things that had happened to me. So that also went along with the fact that I had fragments of memories in lots of instances that didn't really add up or make sense to me. I came to understand my trauma story with the help of Dr. Magnavita and by way of EMDR therapy. And it started with, I remember the first really early on, getting an understanding of what Dr. Magnavita referred to as willful neglect on both of my parents' part. And it did give you an anecdote for any of the people in the audience who are parents. In Denver, Colorado, being put out in the backyard, maybe at 3 years old with bare feet and a diaper, and no supervision of any kind, and wandering out to the back, the back road, and then finding my way down to the intersection in the town we lived in Denver, eventually to be brought back by a neighbor. I think these days that would be called to Child Welfare Services or some government body that something's going wrong in the home, that this is happening. I had a bully at home in the form of my brother. I had a bully at school. Anyone who has ever dealt with being bullied knows you live in a state of terror all the time because you never feel safe. I was abused emotionally, physically, and sexually. And another sort of major theme for me was I really couldn't tune into anything. I was so fragmented. My brain was kind of short-circuited kind of all the time. So I couldn't read for the longest time. And I always had to have, a tutoring outside of school, weekends, et cetera. And another theme for me was what my mother referred to as being accident prone. And so I think by the age of 5, I had maybe 5 or 6 concussions on my forehead, always in the same place. I would fall and hit my head and end up in the ER having stitches in my forehead. But I would say aside from all that, I was fine.
Yeah. So, Michael, can you say a bit more about the different ways that you struggled emotionally and psychologically over the years?
Yeah, due to the neglect, which started for me at pre-verbally, I discovered, I felt alone, unsupported, unloved, insecure, and bottom line, the bottom line was just feeling like worthless. That was my childhood inference. I remember showing a picture of myself around age 3 in Denver, and when I was with maybe a couple of my 2 siblings at the time, and Dr. Magnavita immediately said, you look like a war-torn refugee with just a complete blank stare on my face. He said, that's the telltale sign of neglect in a child. So I was really desperate to escape from my feelings and my situation. So I started creating a false persona, of sort of this perfect persona for the outside world. I became an achievement and status junkie and a workaholic. I couldn't really form authentic, intimate relationships in my life, including with friendships. I had the same 3 terrifying nightmares literally for over 40 years. And I also suffered from things that I didn't know what they were at the time. I know now they were phobias. Starting when I was a boy, I couldn't go to a public restroom. I was afraid of heights. Any suggestion of any kind of intimacy with a woman was completely panic inducing. And the weird thing about this was I just thought this was the way I was, as crazy as that sounds. I had no idea these phobias could be attached or were attached or the result of something at all. No awareness of that at all. So as I got older, drinking became a major theme. Blacking out when drinking became a major theme. And then I added Vicodin into the mix with alcohol as a means of further numbing and escaping.
Mm-hmm. So, Michael, I'm going to jump down a little bit on our outline because I'm aware of the time. And I'm wondering if you could tell people what EMDR therapy was like for you. Tell us about your experience.
So for me, it was unique from the very beginning, and unlike anything I'd ever really experienced before. For me, again, this is just my own interpretation, talk therapy was like reading about pepperoni pizza. EMDR therapy was like smelling it and tasting it and chewing it and swallowing it and digesting an incredible slice of pepperoni pizza, sort of a 3D high def experience by comparison. It was remarkable to me, bearing witness to this excavation, this outpouring of feelings of grief and sadness and anger and loneliness that would come, realizing at the time that they'd been buried deep, deep inside of me since I was a boy. I also realized that these memories had been kind of trapped in my body as well. So I'd have somatic experiences in Dr. Magnavita's office, sort of like feeling that something would come up, rise up, pass through my body, and then kind of never return again, which had an enormous amount of relief every time I would see him. I came to understand what was missing in terms of my early development, got a real understanding of that, and being able to discern the connection between my abuse, my early neglect, and my present day adult symptoms for the first time. Mm-hmm. And then finally, again, one of the billboards talks about this, being able to connect with younger parts of myself that had been injured and had to hide and had to run away, and being able to finally sort of connect with and bring healing and nurturance to those versions, younger versions of me.
Mm-hmm. Great. And maybe as a last question, just to leave people on a note of hope and optimism about what's possible, can you give us a sense of how your life changed as a result of your EMDR therapy with Dr. Magnavita, and how your feelings about yourself changed, how your relationships have changed?
For starters, these nightmares that were as vivid and terrifying the last time I had them as they were the first time I had them went away. The phobias, believe it or not, went away. The PTSD symptoms went away. Addictive behaviors all seemed to stop. And I started kind of taking care of myself, which I wasn't really doing, which Dr. Magnavita talked about when he talked to Debbie the first time that he met me. This fake persona just kind of went away that I'd spent so many years constructing and building. And I found myself kind of living in a more authentic way and freeing myself from this goal set, goal achieved, compulsive, never ending cycle. My total obsession with status, all the trappings of status just evaporated. I look back at my old self, I don't even recognize that person. It seems so funny to me now. Intimacy became a possibility, not only with my friendships, which tend to have been more superficial, but also thinking about the possibility of initiating romantic relationships in my life with women for the first time without this overwhelming sense of panic. And most remarkably, I would say, because my brother was my bully, and was a terrible bully my whole life, and we were estranged until my 60s. And we are now having, because he started his own EMDR journey about 8 months ago, we're having a relationship that we never had for the very first time in our lives. And if I kind of summed it up, I kind of swapped out my old operating system that was all about fear and dread and worry for an operating system that was, I could just wake up and feel sort of neutral and sort of hopeful, and all those things that used to govern me all the time, like an overwhelming sense of dread, which seemed to always be there, just finally were gone.
Yeah. So it's just about time to shift to Q&A. Michael, just 30 seconds. Any final message you'd like to convey to our audience before we go to Q&A?
Yeah. I would say in 2 words, if you or anyone you know are suffering or struggling, and maybe a parent or a spouse or a nephew or a child, don't wait. Don't wait. I spent over 20 years seeking relief. I saw 8 therapists over 20 plus years, talk therapists, CBT therapists, intensive short-term dynamic psychotherapy therapists. And there was really no meaningful or lasting relief. And so by the time I, met Dr. Magnavita and learned about trauma and EMDR therapy, 2/3 of my life arguably was gone. But anyone who's listening today, because EMDR has been around for 35 plus years now, you don't have to wait. So there are qualified therapists all over the world. I don't mean to sound like a commercial or an infomercial, but I've become such an advocate because of the impact it had on my life, and then profoundly the impact it's had on my brother's life and the relationship that we're now finally having because of EMDR therapy.
Yeah. Okay. So we're going to welcome Whitney back, and we're going to move into the Q&A.
Well, thank you. My goodness. And you know what I'd love is for us to have just a back and forth continuation of the dialogue, because as you were both talking, and even just with that last bit, Michael, I couldn't help but think about do-overs, and you talk about do-overs in the book and connected to, we've got a number of questions that we won't be able to get to, so we can talk about them later and put them up on social media if we can.
Absolutely. We'd be happy to respond after we're all done.
That was terrific. And thinking about the do-overs, and Michael, what you're talking about, and your experience in the book is just so powerful. And Debbie, thinking about the neuroscience involved and how the neuroscience and bilateral stimulation works, it is hopeful. And you use the word hopeful. Mm-hmm. I find this very hopeful, this treatment, and how things can be different. So can you say a little bit about how the do-overs work? How you were talking about that in the book, or maybe talking about installing memories when you talk about that.
Debbie?
Yeah. When we talk about do-overs in the book, what often happens as clients get in touch with the experiences from earlier in their life, they start to feel that compassion for their younger selves, right? And they come to recognize how they never got anything close to what they needed growing up, right? And so one of the interventions that what we call an interweave, one of the interweaves that we offer in the course of EMDR is, if you could go back and do for that child, say to that child exactly what she or he needs, right? What would you say? What would you do? How would you reach out? And people usually just run with it, and we keep processing. Or a do-over, like if you could go back into that scene and express anger at the person who hurt you. And let's say you have superhuman strength. Imagine going back, and if there was no concern, no worry about, negative consequences, what would you say? Go ahead and say it. And so we give people a chance to complete actions, right? To see things through to a point of closure. And people get incredible relief in doing that.
And of course, with the neuroscience that we have so much more information about now, you talk about in the window of tolerance, people are with you in treatment, regulated, and able to do this in a different space and time, and the memories are encoded now in a very different way.
Yes, yes. Because they are regulated, they're not out of their window. They are able to observe and witness rather than getting hijacked or overwhelmed by the material. And it's that dual attention, right? Grounded in the present, oriented to the present, feeling safe enough that allows the brain's information processing system to kind of engage and move material to some kind of resolution.
I guess that's another question now. So now practical takeaways, Michael, for everyone on the call and thinking about it. How do you use the work now? How do you remember? How do you use the work? What are some practical takeaways that you have when you get triggered now? It's a tough time for people now, people who are not in EMDR therapy yet, but who need practical takeaways for managing stressful life events. What are you doing now with?
So again, I always want to preface any response like that for me. So it doesn't sound like I'm generalizing for anyone else, but for me. So for me, so much of the work, the reason why the relief and I think the impact it had on my life had to do with feeling like these traumatic memories, which were stuck and horrible, and actually going through them, processing them with Dr. Magdavita over the course of 2 years. I saw him for 2 years, 52 times, as a matter of fact. And my sessions, I went for extended sessions. So my sessions were 3 hours. We do an hour and a half and a break, an hour and a half. And for me, there has not been a lot of subsequent triggering, but I have been back to him as other things have come up. Not only a handful of times, which he invited me to do when we kind of came to closure, so that knowing that his door is open to me. As for example, the whole intimacy specter, that no doubt is going to be triggering in some ways. And I know that I'll probably be having him help me, at those times when that happens. But the beauty for me was, I think it's because it was so pent up for my whole life that the purging and processing of all of those memories was so profoundly cathartic and felt very permanent, like removing splinters, lancing, so they were gone.
Right. Right. Well said.
And how about so many of us, in case, tonight we're virtual, and so much of therapy is being done for obvious reasons virtually right now. One of my favorite pages in the book is to talk about this being an elegant model. Mm-hmm. And your book is an elegant book, I have to say, for many reasons. But the way the right brain to right brain work and really connecting with clients. And, as I'm reading the book, I'm imagining being in the treatment and being with clients and modulating their affect and clients, being self-regulated. It's hard for me to imagine doing that virtually. Does this have to be an in-person treatment, or is it?
Okay, I'm raising my hand because Debbie should answer, but I have to interject that my brother has never seen his therapist, who's a colleague of Debbie's. Mm-hmm. He asked if Debbie, when we finally reconnected, he asked me if Debbie would be able to recommend someone for him. His therapist lives, I think, about a half mile physically from where he lives. He's never seen her in person one time ever. Mm-hmm. He uses therapaddles, so buzz, 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 buzz in his hands, eyes closed, and continues to have the most revelatory experience. And how do I know that? Because for the last 6 months, he and I, 8 months, we've had a call every Friday, which we never miss, for at least an hour and a half. And this may sound weird. It's the most intimate relationship I have in my life that I never, ever, ever, ever thought I would ever have. Mm-hmm. And he's never seen his therapist in person. It's all been virtual.
Yeah. Yeah, it hasn't been a problem working virtually. I mean, it's taken adjusting. I've had to adjust. My clients have had to adjust, obviously. I don't like not being able to see my client's whole body because I'm always tracking what's happening at a whole body level. I have to rely on my clients a lot more to put words on what's happening in their body. And that's something we work on together. But it's actually quite intimate. It can be quite intimate working virtually because you're kind of up close, right? You're really up close with one another. Most people have done quite well with it. Some people have probably done better working virtually than in person, whatever that is, being in their own environment. I think the folks that have had the most difficulty with EMDR working virtually are clients of mine that are farther along the dissociative continuum, which is something I talk about in the book, more complex PTSD with a lot of dissociation, people with dissociative disorders. I think there's something about the safety that we can create in the office that, we create a vessel that really holds the work. That's a lot harder virtually, but I'm doing the work with those folks too. It's just been more of a challenge. Mm-hmm.
It's great. What didn't we ask? Some of these questions are sort of longer questions. Why is bilateral stimulation so important? You did mention people, could watch their windshield wipers, and why is the bilateral stimulation so important?
Yeah, well, if it was as simple as just watching something go back and forth, then everybody would be completely self-actualized, sitting in their car watching their windshield wipers, or going to a tennis match, right, where the ball goes back and forth. It really is the combination of multiple things that we bring to bear in EMDR therapy. It really is, it's not a technique, it's a full psychotherapy. But, what we know about the bilateral stimulation is that it is significant in reducing the vividness of memories, in reducing the negative charge of memories. And it seems to jumpstart the same kind of REM machinery, the same kind of information processing mechanisms that we see and we know from neuroscience. My husband happens to be a sleep researcher. So he and I have had many, he's a cognitive neuroscientist. We've had many conversations about the similarities between the way things unfold and progress in EMDR therapy and what happens during REM sleep and during dreaming. And there really is a movement toward greater clarity, solving problems, more insight that comes with that as well. And so, there's significant research, as I said, that really substantiates that bilateral stimulation increases all of these things that we see, that we associate with REM sleep, like insight, like clarity about information, etc.
And have you found one that's more, you talked about eye movement and the hand pulsers and there's tapping. Is there one particular that there's more research and efficacy?
The research seems to suggest that eye movements are the most effective modality. The other modalities obviously work well enough. Clinicians would not continue to use the other modalities if they didn't work, but the research suggests that the most effective is eye movements. I start every single client with eye movements, and only if they're having trouble with eye movements, I move them to other forms of bilateral. Like some people need to be able to close their eyes to focus inwardly, and we might shift to something other than eye movements. And I just read a study this week looking at virtual treatment, and clearly with virtual treatment, the best results are being seen with eye movement.
Okay. Well, that's wonderful. We are so honored to have had you. Again, I want to make another plug for the book.
It's amazing how fast an hour can go by. I mean, that was felt like about 5 minutes.
And can I just jump in to say the name of the book?
Right.
Stands for EMDR. Every memory deserves respect. We wanted to have a way that people could remember EMDR because it's not easily remembered. And also wanted to let people know that there's an audible version of the book for people who would prefer to listen rather than read, or read and listen.
And it's a therapy that's gaining, a lot of people are very interested in it. I think, we talked previously that all of our therapists are certified clinical trauma professionals. We do have a few that are specifically EMDR trained. Yeah, and it's something that we are looking at having all of our clinicians trained in too. So I look forward to an ongoing discussion, because as you said, it can be its own therapy or an adjunct to treatment, and just a really exciting treatment, and loved talking with you both about it.
Thank you so much.
Thank you for having us.
It's a pleasure.
Our pleasure.
Thanks everyone for coming out.
Thank you everyone for attending.
Good night.
Good night, everyone. Bye-bye.